Our last lecture for biopharmaceutics and pharmacokinetics are the pharmacokinetic parameters. These are the important calculations in pharmacokinetics. First, I will discuss the definition of terms. You all know what bioavailability already is. Bioavailability, or F, is the fraction of administered drug that reaches systemic circulation in unchanged form. F is equal to the amount of drug that enters systemic circulation, or AUC, that's the area under curve, divided by the dose administered. For volume of distribution, it's or letter V, it's the volume that accommodates all the drugs in the body if the concentration throughout was same as in plasma. So how to calculate for distribution, volume of distribution, you just consider the dose administered and you divide it to the plasma drug concentration. Pag sinabi nating VD, pwede kasing yung VD or V, no? If it's volume of distribution, di ba I told you before that ideally dapat mini-measure mismo yung kung gaano kadami yung drug dun sa target tissue ninyo or kung saan saang tissue or organ siya mag-elicit ng action. However, that's a difficult thing to do. Pwede siyang apply for animals because it's very invasive. Pwede lang siyang gawin in animal studies. Especially kapag mamatay naman yung animal, they're meant to die, and then they are just experimental animals, no? Meanwhile, sa humans, ang ginagamit lang kasi natin, the way we can measure the dose of the drug is through the plasma concentration. So now, clearance naman is the volume of plasma containing the total amount of drug that is removed from the body in unit time. EL is rate of elimination over C. Just a quick review of the rates of elimination. We have first order kinetics and zero order kinetics. Most of the drugs in our practice today, they're using first order kinetics. The rate of elimination is through first order kinetics. Pag first order, it's the rate of elimination of drug which is directly proportional to drug concentration. Here, the clearance remains constant. Ibig sabihin, same amount of drug ang laging nakiklear per unit time. Meanwhile, for zero order kinetics, this is only applicable in few drugs. Rate of elimination remains constant irrespective of concentration. So, constant yung rate of elimination dito. Clearance decreases with increase of concentration, so it's indirectly proportional, and the constant amount of drug is eliminated in unit time. Plasma half-life, or T1/2, it's the time required for serum plasma concentrations to decrease by 1/2 or 50%. By formula, we use T1/2 equals 0.693 divided by K, which is the elimination rate constant. Pag sinabi natin elimination rate constant, it's the fraction of total amount of drug removed per unit time. And how do we calculate for the elimination rate constant? We use the clearance and the volume of distribution. So first, if you're given the value of clearance and distribution, volume of distribution, you just divide it, CL over V, makukuha mo na yung elimination rate constant, and then you will use this value para i-divide yung 0.693 divided by K. So, complete drug elimination can occur in 4 to 5 half-life. Yung sinasabi nating state. Next, for the steady plasma concentration, or CP, C sub PSS, no? That's the concentration na steady state plasma. Okay? Yung plasma na steady state, ano yung concentration niya by steady state? So, it's repeated drug administration at relatively short interval of time. The input of drug balance must be equal to the clearance. So, ang CPSS is computed by dividing clearance from dose rate. So, dose rate divided by clearance. From this equation, it is clear that dose rate can be calculated if clearance and target concentration of plasma steady state of drug is known. Yan. Yung equation kanina na sinabi natin na kung saan yung dose rate divided by clearance, makukuha mo na yung concentration in plasma steady state. Yung early equation na yon, it's valid only for drug administration where the bioavailability or F is 100%, such as yung IV. IV parenteral. But where it falls short, the equation turns to be dose rate is equal to target CPPS times clearance divided by F. Okay? Pag hindi 100% yung bioavailability, you compute it this way. Both this equation stands valid for the drugs following first-order kinetics. Again, pag 100% bioavailability, the formula is CPSS equals dose rate divided by clearance. Kasi it is already understood here that the bioavailability is 100%. So you don't need the value of bioavailability already. Alright, pag may Kellis-Menten kinetics, ang ibig sabihin dito, there is change, no? The elimination changes from first order to zero order over the therapeutic range. This signifies that till the saturation level of drug, CPSS is related to dose rate. So, lagi ang CPSS is may relationship sa dose rate. Okay? And then, but it turns out of proportion beyond it. So, rate of drug elimination. Ito lang, basta tatandaan nyo lang yung formula. Rate of drug elimination equals Vmax times C over Km plus C. So, yung Km, plasma concentration at which elimination rate is half maximal. And then C is the plasma concentration of drug. Vmax is the maximum rate of drug elimination. Example ng nag-a-apply ng Kellis-Menten kinetics is phenytoin. It depends on the therapeutic dose kung mag-shift siya from first order to zero kinetic. So, I just want you to focus on the formula dito sa my Kellis-Menten kinetics. Sabi niya, ang rate of drug elimination, you depended on the factors such as yung maximum rate of drug elimination mo na Vmax. I-multiply mo siya sa concentration ng drug mo sa plasma. Tapos, i-divide mo siya sa Km. Km kasi is plasma concentration at which elimination rate is half maximal. Anong plasma concentration? Yung elimination rate mo is half pa lang nung maximum na elimination rate niya. Okay? At what point? At what concentration? And then C, of course, the plasma concentration of drug again. So, pag ganito naman, all the values are being provided. You just have to memorize the formula. The plateau principle of drug accumulation. So, ito yung basis natin. Kaya may half-life. Kaya kailangan nating mag-dosing. For example, every 8 hours, every 12 hours, ganun, no? So, when constant dose of a drug is repeated before the expiry of 41/2, it would achieve higher peak concentration because some remnant drug will be present in the body. Subsequently, plasma concentration becomes constant and forms a plateau and fluctuates around the desired therapeutic level of a drug. The desired therapeutic level reaches 4 to 5 half-lives. Alright. So, baka nalilito kasi kayo, class, no? Just to give you a background, ano ba ang steady state concentration? When we say steady state concentration or CSS, it occurs when the amount of a drug being absorbed is the same amount that's being cleared from the body when the drug is given continuously or repeatedly. So, ganito nyo siya iisipin. Imagine, pag absent yung coworker, tapos nag-iwan siya ng masarap na chocolate sa office. You who's left in the office is attracted to the chocolate. So, you get 2 chocolates. The next morning, ni-replace mo yung chocolates na yun. So, your office mate will not be able to notice. But and then in the afternoon, she's out again. So, you boldly take again 3 chocolates. And then the following morning, i-replace mo na naman siya. So, as this continues, the chocolates are in a steady state. Meaning the number of chocolates does not change from day to day. Every time a chocolate is taken, it's replaced in the box. The input rate is the same as the elimination rate. Ganun lang kasimple ang steady state. So, you'd probably ask, class, ano bang importance ng 4 to 5 half-lives na sinasabing steady state? Ganito, class. If we continue dosing at the same frequency, the amount we dose will be eliminated during each dosing interval. As a result, yung drug concentrations in the body, it will remain constant or steady. Because those drugs, class, meron kasi silang constant elimination rate. So, now your problem is you have to replace it, no? Kaya tayo may tinatawag, that's the importance of having T1 half or knowing the half-life. Kailan yung 50% matatanggal sa body? At what rate? anong time siya magiging 50% na lang. And by that time, we have to replace it. Sabi nila it takes 4 to 5 half-lives para ma-reach daw ang steady state. Ibig sabihin, after 4 half-lives, constant nang may reserve ka ng drug dun sa body. The drug particles of the drug component. Very important class. Steady state concentration, it is the time during which the concentration remains stable or consistent when the drug is given repeatedly or continuously, for example, yung mga IV infusion. So the time to reach steady state is a function of T1 half or half-life and is achieved when the rate of the drug entering the systemic circulation equals the rate of elimination. So for most drugs, approximately 5 half-lives ang kailangan para ma-reach ang steady state. Of course, the time to reach steady state is hindi siya nagde-depend sa dose size, dosing interval, and number of doses. It's always depending on the half-life. After every 4 to 5 half-life, the drug concentration falls to almost 3 to 4%. Okay? So, ang implication lang nitong picture na to class, y-axis drug concentration, x-axis time. Kapag nagbigay ka ng drug, okay, na hindi mo finalo yung desired half-life. For example, the half-life is 4 hours, tapos nagbigay ka ng next drug mo around after 6 hours. For example, talagang magde-decrease ang drug concentration mo. Magde-decrease siya na pwedeng to the point na walang natirang drug concentration inside the body, wala kang reserve. So, kaya umaabot siya, bumabagsak siya papunta dun sa zero. Nakikita niyo yung dosing interval sa next dose, bumagsak kasi yung una, papunta sa zero. Next dose, same concentration lang na ibigay niya. And then compare it sa next diagram mo. Kasi sa next dose, hindi ka nag-increase ng drug concentration mo sa katawan. Pansin nyo dito, the dose is repeated before the expiry of 4 to 5 half-lives. The concentration of drug keeps on increasing after every subsequent dose. Ang nangyayari dito, hindi siya bumabagsak sa zero. So, bago pa siya mag-fall down, nagbigay ka na ng next dose mo, meron ka pa rin ng drug inside the plasma or inside the blood. So, hindi ka mawawalan ng drug concentration inside the body, ready to elicit the effect. So, what happens is, nagkakaroon ng accumulation. Administered drug is not completely eliminated during interval. Steady state drug intake equals elimination during dose interval. So, yun ang meaning ng steady state. Diba? So, dito, nakikita nyo, nagkakaroon ng accumulation. Meron pa ring drug concentration inside the body. So, for example, yung sa mga antibiotics, your bacteria, your virus, your pathogenic microorganisms, they are known to multiply. So, it is important na laging meron kang reserve na drug concentration inside the plasma, inside the serum, to act on those pathogenic microorganisms. Kaya, before pa mag-expire yung half-life niya, kailangan magbigay ka na ulit ng next dose mo. Okay? Para increasing frequency, increasing concentration ng drug, okay, after every subsequent dose, increase din yung magiging effect niya. Magkakaroon ng accumulation, and then pag may accumulation of those drug particles of the drug's concentration inside the plasma, inside the body, inside the serum, inside the blood, nagkakaroon ng immediate action in case na may invasion pa ng microorganisms. I will give you another example. Okay? For example, yung mga patients na masakit ang ngipin, sobrang sakit, di ba, hindi agad binubunutan. And then, ang advice ng dentist is mag-take ka muna ng mefenamic acid 3 times a day for 7 days. And then, amoxicillin 3 times a day for 7 days. And then, balik ka dito pag hindi na masakit, saka natin bubunutin. Ano kaya ang rasyonale ni Doc? Bakit niya ginawa yun? Bakit kaya kailangan pa 7 days ka niya muna ng medicines bago niya mabunutan? Because pag mabubunutan, sobrang sakit. Okay? And sobrang madugo, prone sa infection. So, ang ginagawa nila, at least if you have maintained religiously the 7 days times 3 doses ng mga drugs na yun, sure si Doc na andun yung drugs, present siya inside your blood, inside the plasma, and ready to act when the surgery happens. Okay? So, ito pa. Administer the drug in small dose over small regular intervals rather than large dose in large intervals of time. Pansinin nyo, yung green 4 times daily na 50 mg, yung blue 2 times daily 100 mg, and yung pink once lang daily pero 200 mg. Mataas yung dose, tapos minsan lang siya iti-take. Tapos matagal yung interval niya, like for the next day na ulit siya iti-take. So ang nangyayari dyan, since once mo lang siya tinake, yung drug, once mo lang siya tinake, probably babagsak ang concentration niya and you have to wait again for the next day. Matagal yung oras na antayin mo to administer your next drug. The disadvantage is, pwedeng bumaba yung drug concentration mo. A certain time, for example, in-administer mo siya ng umaga, at a certain period of time, kunwari hapon na or magagabi na, pwedeng mababa na lang yung drug concentration mo sa katawan. Ayan. So, these are some drugs, okay? Example, yung mga with narrow safety margin with unquantified pharmacokinetic data. Ang strategy lang siya dyan sa pag-administer is we can, case-to-case basis, sa bawat drug, meron siyang range of therapeutic concentrations. And then, bawat therapeutic concentration na yon is itatrial kung ano ba ang mag-best fit for the patient. Examples na may narrow safety margin with limited pharmacokinetic data: anticonvulsants, antidepressants, lithium, antiarrhythmics, theophylline, and some antimicrobials. Drugs naman with short half-lives, ang strategy mo dyan, conventional interval, 6 to 12 hours, fluctuating plasma concentration. Examples, pen, ampi, chloram, erythro, more antibiotics, and propranolol. How about yung mga drugs na may long half-life, such as the MAO inhibitors? These are CNS drugs. Reserpine also for antihypertension, and omeprazole, PPI, or proton pump inhibitor used for gastric ulcers, peptic ulcer disease, acute gastritis. Okay? So, pag long half-life, pwedeng strategy mo, give daily, weekly, or as a single dose. Omeprazole is given only once a day, 30 minutes before breakfast. For those with steady drug concentration, strategy is note the loading dose and the maintenance dose, and an example of this are mga steroid. Loading dose, single or few quickly repeated doses to attain target concentration rapidly. So, gusto mo agad ma-reach yung concentration mo, mataas agad yung concentration mo sa blood, you give the loading dose, and after dun to follow na lang maintenance dose mo. Usually, the loading dose is mataas talaga. Especially, ito yung mga patients, for example, na pupunta sa emergency room, sobrang in pain, for example, and then mataas ang kanilang bacterial content na nakita sa CBC or sa urinalysis. Leukocytosis, obvious leukocytosis, high in WBCs. Ang gagawin sa patients na to, bibigyan namin agad ng loading dose, mataas na dose ng ating antimicrobial agent. Loading dose is target concentration times volume over bioavailability. Loading dose is governed by volume of distribution. Please remember that. For maintenance dose, it's the amount of drug given to maintain the steady-state plasma concentration of drug at regular intervals so as to balance the elimination. Dose rate is equal to target concentration of plasma steady-state times clearance divided by bioavailability. So it is dependent on clearance or half-life of drug. Remember, pag loading dose, dependent on the volume of distribution. If it's maintenance dose, it depends on the clearance or half-life of drug. Kaya mo nga siya i-maintain because it's being cleared out, it's being eliminated. So you have to know what is the clearance of the drug, what is the half-life of the drug, so that alam mo kung ano ba ang maintenance dose na ibibigay mo. Therapeutic Drug Monitoring or TDM, CPSS of a drug depends on its bioavailability, volume of distribution, and clearance. Each of these parameters varies from patient to patient. Measurement of plasma concentration of drug after initial drug administration can give all these parameters of an individual. This helps for subsequent quantification of drug dose regimen. Why do we have to monitor the therapeutic drug concentrations, the therapeutic drug parameters? Because some drugs have low safety margins such as digoxin, anticonvulsants, antiarrhythmics, theophylline, aminoglycosides, lithium, or yung mga tricyclic antidepressants. Basta yung mga may narrow therapeutic index. If individual variation are large, okay, lalo na sa mga binibigyan ng antidepressant and lithium. So, ang dosing sa mga to ay case-to-case basis because we have also to consider the individual factors, yung patient factors. Potentially toxic drug used in renal failure like aminoglycosides, antibiotics, and vancomycin. In cases of also of poisoning, failure of response without any reason, and of course, patient compliance. Next, prolongation of drug action. Why is there a need to prolong the drug action? Bakit some drugs, they are in long half-lives, no? They are readily made to have long half-lives because of first, these are the factors, these are the reasons rather. Frequency of drug administration. Kaya pinapahaba na lang ang drug action, ang half-life ng ibang drugs, okay? Kasi yung iba, inability to cater yung too frequent na drug administration. And then also for improved patient compliance. And then large fluctuation of plasma concentration should be avoided, can be avoided. Pag frequent kasi laging bigay ng bigay, pwedeng biglang may fluctuation din ng plasma concentration. Na pagbigay ka ng bigay and then malaki pa yung dose, okay? Pero pag meron naman yung iba na small intervals pero small doses naman, that's accepted. Parang nasa figure kanina or picture kanina. And then drug effect could be maintained overnight without disturbing sleep para hindi ka na mag-administer ng alas 12, ng alauna, gigising madaling araw si lola, si lolo para lang ibigay yung oral tab nila. So yung iba, in prolonged drug action na sila, readily made as drugs with long half-lives with prolonged drug action. Kaya nga meron din tayong preparations na extended release, sustained release, etc. All drugs can be made long-acting, for example, yung mga sedatives, those for headache remedies. A method to achieve this objective, prolonging the absorption from site of administration. Yan, the sustained-release tablets, Pansos, for parenteral using oily solvents, yung mga insoluble form natin. And then, mga pellet implantation, Cialistic, and biodegradable implants, and then inclusion also of vasoconstriction. Like for example, some drugs are administered together with other drugs for better absorption and then prolonged action of the other drug administered concomitantly with it. No, yung isang drug mag-act as vasoconstrictor and then yung isang tutulungan niya itong isang kasama niyang drug para mas ma-absorb siya, mas matagal yung effect niya through vasoconstriction, and then also transdermal patches. What else? You increase plasma protein binding para prolong sa body, and then retard metabolism, retard elimination.